Hello, everyone. Thank you for joining us for Global Health Grand Rounds today. I am thrilled to be able to introduce our two speakers. Our first speaker, Brian Willis, he's going to start for a short presentation. He worked at the CDC from 1990 until 2002, when he left to focus on the health impact of sex trafficking and sex work on mothers and their children. After working with partners on several studies, he founded Global Health Promise in 2007. The mission of GHP is to research the unmet maternal needs of sex workers and needs of their children, develop and implement programs to address these needs with local partners and advocacy. Most recently, Brian coordinated a study in 8 low and middle income countries during 2019 and a study in 3 countries in sub-Saharan Africa from 2022 to 2023. Programmatically, Brian partnered with organizations in Uganda to start an informal school for children of female sex workers and a maternal health program for female sex workers in Nigeria. Dr. Wendy Macias-Konstantopoulos is then going to speak. She is a physician. She also has an MPH and an MBA. She's an associate professor of emergency medicine at Harvard Medical School and attending emergency physician at Mass General Hospital, where she directs the Center for Social Justice and Health Equity. She is the MGH Endowed Chair for Leadership in Emergency Medicine and founding executive and medical director of the Mass General Freedom Clinic, which is an innovative healthcare clinic for human trafficking survivors that won the 2014 Partnership for Freedom National Competition. Her global and domestic areas of research and programmatic expertise include sexual violence, human exploitation and trafficking, substance use, and structural gaps perpetuating health inequalities among underserved populations. She remains focused on global health issues related to gender-based violence through partnerships with entities such as Physicians for Human Rights and Global Health Promise, where she serves as Global Policy Advisor. Thank you so much to both of you for coming. We're delighted to hear you speak. So Brian, I hand it off to you.
Thank you very much, and good morning, everyone, and thank you for joining us today. Wendy, will you be flipping through the slides? Thank you. First, just want to start with disclosures that we have no financial or commercial interest to disclose, and the funder for the 2019 study, which we are discussing today, had no role in the study design or data collection, interpretation, or preparing of the manuscript. As noted, we focus on 3 primary issues: research, service, our programs, advocacy, and strategic partnership. So in our work, our research informs our services and our programs. We also use our research to advocate for sex workers and their children. And then we develop and build and coordinate strategic partnership of our local partners, many of whom are sex worker organizations, and build partnerships with other organizations that address sexual and reproductive health, maternal health, and child health. Looking at our vision there, the core work of our organization is based on human rights, and that's the rights of all sex workers and their children to enjoy the full retinue of their human rights. We have a small program in the United States and also work with a number of other organizations, as mentioned, in Uganda and Nigeria, and then we do research in a number of other countries. For today's presentation, we have 3 objectives: to identify the methods used to account for deaths, particularly of women in low and middle income countries, and then review the leading causes of death that we identified in this study. And then we're going to discuss potential programs and policies to prevent these deaths in the future.
Good morning, everyone. Thank you so much for being here so early in the morning, and thank you for the introduction. I'm having a little bit of a sticky tab here in terms of advancing, but I will do my best with advancing slides appropriately. So this is a citation to the study. I just want to make sure that everyone knows that this has already been published. And I just want to begin with acknowledging all our partners in the local areas in which the study was performed and all the women who participated in our study. It's an extensive amount of work and coordination that happens on the ground, and it really could not be achieved without the local input that we receive from our local partners. So this is kind of an executive summary of the study. And we'll review this as we progress through this presentation. But essentially, we had 1,280 participants across 8 countries in 3 major global regions. We received reports on 2,112 female sex worker deaths. Nearly 2/3 of these deaths were maternal deaths. And abortion was the most common cause of all deaths and of all maternal deaths, but all deaths of all causes. Most deaths were among female sex workers in the ages of 20 to 29. And as a result of these deaths, 3,659 children lost their mothers. So just to provide a little bit of background, the majority of studies on female sex workers that are available in the literature, and there's a great vast amount of it in low and middle income countries, focus on causes of morbidity. So this includes HIV, hepatitis C, as well as mental health and behavioral health morbidities. Data on causes of mortality is actually pretty scarce when you look at the literature. There are 2 studies in lower income countries of Burkina Faso and India that were HIV-related mortality studies. And there's 1 study also carried out by Global Health Promise in Cambodia, and that was an any cause mortality study. There are 2 other studies in high income countries in the US mainly that look at mortality among female sex workers, but that is about it following an extensive review of the literature. So identifying causes of mortality among female sex workers in low and middle income countries is really challenging for 2 major reasons. One, the fact that we're working in low and middle income countries means that we are essentially dealing with incomplete civil registration and vital statistics data that don't necessarily capture all segments of the population. In addition, because we are dealing with a socially marginalized group of female sex workers, these women are often excluded from these vital statistics and civil registration systems, right? So they may actually also give birth to children that are never registered. So the birth of those children are nowhere in the system. They also have decreased access to resources within society, so they may not access healthcare facilities, and that kind of excludes them from any health facility data that enters into some of these studies in more robust regions. And then some of those deaths are clandestine deaths where, especially if they die in a brothel, for example, brothel owners may end up dragging out the bodies in the middle of the night and, burying them in shallow graves, and those deaths are not registered either. So you can see that this is a pretty difficult subpopulation to study. For those who are in official registries, who either died in a healthcare facility or in some other way have been registered, they may not be identified in those death certificates as a female sex worker. So again, it's not easy to go and request those types of reports and have a clean study. So cause-specific mortality among marginalized subpopulations in these countries that perhaps even lack robust national systems of civil registration and vital statistics really requires other alternative methods of monitoring for mortality. And a lot of this work has been done, so you will see that we borrow from other work in maternal death. The goal of this study was to identify causes of mortality among female sex worker communities in these 8 countries across 3 global regions. So we'll talk a little bit about the study site selection. In order to look at this population, we wanted to really have geographic diversity. and wanted to look at just more than one region of the world. Here in this map, you see that mostly focused on Africa. We have 5 countries from Africa, and these countries were selected because of a large female sex worker population, high maternal mortality rate, high HIV infection rate among female sex workers that documented in previous data reports, and the presence of local partners with whom we could work with who were known to female sex workers and who would have access to this population. So the study was conducted in the field between January 16th and October 1st of 2019. And again, we have the 5 countries in Africa that were selected, 2 countries in the Asia Pacific region, India and Indonesia, and 1 country in South America, Brazil. And the cities within each of these countries were selected with the assistance of local and national partners, considering that we wanted to both have some data around urban and rural settings, but wanted to make sure that access was going to be feasible through our local partners. So study participants included female sex workers, and eligibility for female sex workers to participate in the study was something that our local partners were very helpful in. They also helped to recruit them in areas where female sex workers might either work or otherwise be located. And the criteria that were determined to determine eligibility for these participants were ages greater than 18. So the female sex worker had to be 18 or older, had to be a mother to at least 1 child under the age of 10, had to be engaged in full-time sex work in the preceding 3 years, and socially engaged or interactive with other female sex workers in the community. So really had to know about what was happening within that community of female sex workers. Study participants were verbally consented, and they were asked to provide detailed information about deaths among female sex workers within their community. And these groups of female sex workers were gathered, were convened in the locations where our local partners felt that female sex workers would be most likely to feel safe and would feel that it was acceptable for this group to meet and to provide this information. So a major challenge to identifying causes of female sex workers in low middle income countries, as we discussed, is the lack of health data in this population. And this has been a particular concern with maternal mortality, and not just in female sex worker populations, but in the broader community of women in these countries. So to compensate for that, numerous methodologies have been developed to account for these deaths that occur perhaps outside of health facilities and go unaccounted for. These methods include things such as maternal death surveillance response systems, which we will talk about, reproductive age mortality studies, household surveys, which most of you are familiar with, maid-in, maid-for method, the sisterhood method, the key informant method, and the community knowledge approach. And all these methods have limitations of their own. They're either not fully accurate or comprehensive. They're either very time intensive or very costly. But each of them have their pros and cons, and it may or may not be suitable for local NGOs and governments to use these methods. In this study, we employed the CKA method to identify information about death. And these detailed reports that we received from women, as much as we could, we made these reports as close to a verbal autopsy as possible, given the knowledge that was available to the women. So looking at the types of methods that are used to account for deaths, I just want to focus in on a few of these. So we are probably all pretty familiar with the house-to-house survey, the household survey, using quantitative questionnaires where you really try to get a large probability sample and and get as close as possible to what would be considered an objective measurement of population. There are other, as we mentioned, methodologies that have been developed, and I will touch upon the made in, made for methodology. So this methodology is basically first looked at in Indonesia, looking for maternal deaths, and informants who were birth attendants in these communities met 2 to 3 times a month with an interviewer who confirmed the details of the death by visiting the households of the deceased to interview family members. The key informant methodology in India, also looking at maternal deaths. The key informant methodology is the one that I just mentioned in India that met with birth attendants. The made in, made for methodology was in Indonesia, and that's a pregnancy-related death study where the informants were village leaders as well as health volunteers, and they completed paper form questionnaires, qualitative questionnaires about deaths. These were brought to an open meeting for review and discussion, and any corrections to the deaths were made at that point. And then the study researchers took those reports and confirmed the reports by household visits to the home of the disease, and they found a 92% sensitivity with that. We also have maternal death surveillance response systems, which are much closer to a CRVS type of system. And it's a continuous cycle of maternal death identification, notification, and review. So basically you have health workers in the communities that identify a probable maternal death in the community, notify the maternal death review committees, where a verbal autopsy is used to collect information from the family. The maternal death review committee determines probable cause and then feeds that information to the district, region, or country maternal death review committee, who then analyzes the case, makes recommendations to prevent these types of deaths in the future, and feeds it back into the system. So that's a nice system of feedback. And then finally, we have the community knowledge approach, which probably lands somewhere in between all of these. Wait, see if I can go back. Somewhere between all of these, where we are able to access a small probability sample within the community to inquire in an open focus meeting fashion, similar to the sisterhood and other types of methodologies. In that fashion, we collect information about deaths as close to what a verbal autopsy might look like, and then confirm sensitivity with house-to-house methods. So this study was, the CKA was validated in Bangladesh, and the validation study used the house-to-house survey method as the gold standard. They were able to identify neonatal, jaundice-associated, and maternal deaths among women living in communities with sensitivities between 80 and 100%, and maternal deaths with 100% sensitivity. They were also able to capture 94% of all-cause deaths among persons greater than age 14 and older, and also confirmed it with house-to-house surveys. So this validation study, compared to the house-to-house survey, was also found to be more efficient, meaning that it required less staff, less time, and less money to conduct. So essentially, it's more efficient and has a high sensitivity. And while this methodology was not necessarily designed for communities of women who engaged in female sex work, we aimed to use the CKA to identify mortality in this particular subpopulation of women. So we used a questionnaire to obtain detailed information, including the woman's name, the age of the woman at the time of death, the city and country where the death occurred, the year of the death, and the pregnancy status of deceased women. And we had a look back period of 5 years. Any known details surrounding the death were recorded, including details about the circumstances around the death, especially during or after birth, where the woman died, and how many children she had who were alive at the time of her death. And if the participant reported that the woman had died after an abortion, we attempted to understand the method of abortion that was used in that situation. So we had a total of 8 countries visited, 24 cities between January and September. We had a total of 165 of these focus groups and 1,280 participants. We then took those reports of the deaths and coded them in accordance to what we were essentially understanding were the causes of death among this population. So they were coded as either abortion, murder, HIV/AIDS, suicide, accident, etc. The coding was performed by 2 members of the research team. And for those deaths that would fall potentially under maternal death, those classifications and deaths were reviewed and performed by the lead field investigator, an obstetrician gynecologist, and a 3rd member of the team. Maternal deaths were coded in accordance with the World Health Organization International Classification of Diseases and Maternal Mortality System. Okay, so let's talk a little bit about what we found. Again, the death count was 2,112 unique female sex worker deaths reported between 2014 and 2019. More than half of these were reported to have occurred in 2019. About a quarter of them, 24.1%, were in 2018, and the remainder, 17.5% of the remaining deaths were reported to have occurred between 2014 and 2017. So you can see that the majority of these deaths were in the preceding year and a half. And that's not unexpected or surprising, given the role of recall bias. The most recent deaths are probably fresher in their memory and mind. And so those are the ones that not only are recalled first and reported, but they also have a high level of detail associated with these reports. These are probably deaths that are pretty reliable in terms of our confidence in the report. I just wanted to caution against making any sort of conclusions about the distribution across the years of these deaths. We can't really make any conclusions about this, and there are several reasons for that. Again, the recall bias will favor report of more recent deaths rather than older deaths. It doesn't necessarily mean that only 370 deaths occurred in the first 3 years of this look back period. We only have a finite amount of time to collect this information. So I just wanted to caution against that. Okay. So here's some results, and this is a busy table, but I'll try to focus in on what matters here. Essentially, what we found is that maternal deaths accounted for the large majority of deaths among this population, with 1,320 deaths, and that was 62.5% of the 2,112 deaths. The majority of these deaths occurred in the 3 sub-Saharan countries of Kenya, Nigeria, and the DRC. And what we also found that in that left column of maternal deaths are included 750 abortions, which accounted for 56.8% of the total 1,320 maternal deaths, 174 suicides, which accounted for 13.12 of those maternal deaths, and 112 obstetric hemorrhages, accounting for 8.5 of maternal deaths. So collectively, maternal deaths really were the majority of the deaths, with abortion being the majority of all deaths across the study from all causes. If we then take the 174 suicides that were deemed maternal deaths and include that with the 114 non-maternal deaths, suicides. Suicide was the second leading cause of death across the study, accounting for 13.6% of all deaths reported. And this was followed by 265 or 12.5 deaths attributed to murder and 7.4 deaths attributed to HIV/AIDS. So this is just another sort of more visual look at these data, and mostly just to point out the disproportionate report of deaths in Kenya, Nigeria, and DRC, with a large proportion of those being maternal and abortion related deaths in the light blue and light green. So if we just focus in on maternal deaths, we want to again point out that the majority of the abortions, abortion being the majority of maternal deaths, with 56.8% of the 1320 deaths, these took place in the 3 sub-Saharan African countries of Kenya, Nigeria, and DRC. 94.4% of these were in these 3 countries. But if you add the other 2 sub-Saharan countries, it basically is the majority of all abortions happening in Africa. And if you look at the contribution to the total maternal death, of these deaths accounted for 57.4, which is really a stark difference to World Health Organization reports of these deaths accounting for 10% of maternal mortality. Again, this is not maternal mortality rate, so it's difficult to know how to compare the two, but it calls into question whether or not the maternal mortality, if we were able to calculate it, would be larger in this subpopulation of women. In terms of suicide, suicide during pregnancy, if you look at reports in the literature and across countries, suicide during pregnancy is more rare than it is in the postpartum period, accounting for about 1% of maternal deaths. And in this case, we did find that suicide during pregnancy was a larger proportion of the suicides, the maternal suicides. But altogether, they accounted for 13.2% of the maternal deaths. Another visual of the abortion contribution and suicide. I think this one only includes suicide within 2 months of birth. Causes of non-maternal mortality. So I've taken out the maternal death here in this table and just focused on non-maternal mortality. And you can see that non-maternal mortality there were 792 deaths in this case. So they were about 37.5% of all deaths reported across the study. And in this case, murder accounts for 33.5% of non-maternal deaths. HIV/AIDS accounts for 19.8% of non-maternal deaths. And suicide accounts for 14.4% of non-maternal deaths. These percentages that you see here are percentages of all causes, including maternal death. And here's another visual with just the distribution of the various different types of deaths that were reported across these cities and countries. All right, finally, we want to look a little bit about at the age group of these women. And we found that the age group that had the most proportion of deaths was the 20 to 29 years of age, with 57.2% of the deaths. And that was followed by the 30 to 39-year-old group age, and finally the 11 to 19-year-old group age. And within the 20 to 29-year-old age group, you can see that abortion was the largest number of deaths, and then followed that by other maternal deaths, not including abortion, and follow that by murder. So in these top three age groups that were affected by deaths it was largely driven by abortion, other causes of maternal death, and murder in these age groups, with the young 11 to 19-year-olds. And I should say that the youngest age reported at death was 13 years of age, but this group being most affected by abortion. Here's a visual as well. And then finally, we wanted to look at the location of death. So we wanted to understand if these women were making it to hospitals or mostly dying outside of hospitals. And you can see the distribution of the maternal deaths here in terms of, those deaths in which we know where their location was. The location was reported more often in maternal deaths. So we have the report of where a woman died in 750 in 70.5% of those cases, whereas in non-maternal deaths, we only know the location in 15.2% of those cases. So location was mostly more likely to be reported in maternal cases. And this is a distribution of where these deaths are occurring. So abortions are largely occurring outside of the hospitals, with 57.3% of those being outside at either their home or at work. And then the other maternal deaths are also occurring largely outside of hospitals, and the peripartum deaths are occurring some outside and some in hospitals. Children left without mothers is something that we really were focused on understanding. And we found that of these 2,112 female sex workers, 77.1% had at least one child that was alive at the time of death. And a total of 3,659 children were left without mothers, which averages out to about 2.25 children per mother. Some of the limitations of the study, the data were collected at different times in different months across the year of 2009 between January and September. And so the January focus groups were likely to be reporting 2018 deaths, whereas the later 2019 months were likely to be reporting 2019 deaths. There were time constraints, so we couldn't exhaust the memory of all these study participants and gather as much information about older deaths than newer or more recent deaths. And we were unable to compare the reports of these deaths to community health facility in the community to health facility records or civil registries. Especially for those deaths that were occurring outside of medical facilities, it was unclear how or where we would go to confirm and triangulate these findings. But because the CKA has been found to be highly sensitive for identifying maternal causes of death, we are hopeful that these are reports that we can be confident about. And although the CKA validation study did not include women who identified as sex workers, we believe that, and has not been validated specifically among sex workers, we believe that the same sensitivity might be present here as well. It's also important just to mention that the house-to-house confirmation of these deaths is very difficult, because women may be estranged from their families and have been out of the home for many years, where their families may not know much about what's going on in their lives, may not know that they are female sex workers, and may not know the circumstances surrounding their death, or even know that their family member has died. Study participants were primarily recruited from urban female sex worker communities, so we didn't get as much information about rural. It was much harder to access female sex worker communities in rural areas, and that may limit the ability to extend this sort of data to the rural regions in these countries. And may not be representative of what's happening in the rural areas. All right, I'm going to pass back to Brian for the remainder.
Thank you very much. And I'll let you click to the next one. There we go. So as was explained, that for most of the female sex workers in these 8 countries, maternal causes of death were disproportionately contributed to the overall causes of mortality that were reported to us. So looking at the maternal death, we're looking at what we can do to address that situation. So that would mean increasing access to reproductive health, prenatal and perinatal health care. Is critically important, both to reduce the deaths from unsafe abortion and post-abortion complications, and also to reduce the maternal deaths that occur during pregnancy, delivery, and postpartum period. We're especially concerned about the abortion-related deaths, and so clearly increasing women's access to effective long-term contraception, safe abortion, as I mentioned, post-abortion care is critical to ongoing efforts to prevent those deaths. We believe that the CKA method may be a very good option for our local partners, the sex worker organizations and the organizations that work with sex workers, in order to identify the causes of death in their community, and it could be done rapidly and almost reflect real-time occurrence, given that the reports that the women provide are most often the most recent ones. So they would be acting on the most recent causes. I mean, as far as recent causes, it could be some of the deaths are reported the same day, day before, week before, so they are very recently reported deaths. We also recognize the importance to look at the impact on the children of female sex workers in order to help our local partners and local governments and other NGOs to help the children who are orphaned, oftentimes orphaned by their mothers, left motherless. Oftentimes the mother is the primary care provider. So some of these, we also track what happens to some of these children and where they're left and who cares for them. So these children are very vulnerable when their mothers die. We strongly believe that the data on mortality among female sex workers should be collected by the local partners, so they have local information to inform their local interventions. But the data collected at the local level can then be aggregated at the national level, and then we can look at the national data across regions and ultimately at a global level. That's what's done for HIV. And this is a way for us to identify what is currently going on, implement interventions in order to address the current causes, and will allow us to perhaps identify the effectiveness of those interventions down the road. None of this will happen, just the last point there is, none of this will happen without the financial support from foundations and governments and UN agencies. So COVID-19, so as was explained, we did this data collection through 2019, ending on October 1. March, we all know that in March 2020, with everything shutting down with COVID, it changed the dynamics of what was happening in many of these countries. In fact, I was with my colleagues in Sub-Saharan Africa, meeting with them to share the preliminary results of this study, when the countries were shut down. So it ended our ability to personally meet with our partners and local organizations to share these results. But it also, during that period, shifted some of the needs that we identified through our partners for female sex workers and their children, most particularly food insecurity, vaccine hesitancy. And so at the next slide, you'll see that we responded to some of those needs. And then it also, from 2019 and the current situation with COVID and the pandemic and food insecurity, it informs our future directions as far as research, looking at what is happening with the women and the children now, well, in 2022 during the pandemic, and also moving 2023 out of the pandemic, but also influenced by social instability in some of the countries during elections, financial crisis in some of the countries, and very high and pervasive inflation in some countries that takes a disproportionate toll on vulnerable populations, including female sex workers and their children. So the 2019 study helped us identify a couple of other questions that we need to look at going forward. And that's what we're doing in Kenya, Nigeria, and the DRC. We wrapped up the data collection in DRC in March. And so we're doing our analysis and should have results from some of that data collection, particularly the mortality data, within the next couple of months. We also look at how this, I mentioned at the very beginning that our research informs programs and policies. So the data from 2019 informs some opportunities for interventions, particularly the need for increased access to family planning and reproductive health care, especially long-term effective contraception for the women, and also safe and respectful abortion and post-abortion care. We also, it's clear that in many of these communities, the women need access to safe and affordable and respectable maternal health care and neonatal health care and HIV prevention during pregnancy. And also there's a great need for support for mental health services, especially for the women who are pregnant or have recently given birth. One aspect that we see on the right-hand side there that is important to note, and this is one of the things that we do, is we really listen to the mothers that we work with. And while they were reporting many health problems and death among their colleagues, one of the things they made clear to us among their priorities was alternative sources of income. So this is, we listen to the women we work with, the mothers we work with, and that was very clear from the discussion with them also, is that they're facing very high rates of very high, many deaths of women in the community, but they also really want to have alternative sources of income. All right, we will leave it there, but we look forward to any questions or comments from all of you. Thank you.
Well, thank you for an incredible talk, both of you. Thank you for drawing the world's attention to the plight of such an incredibly vulnerable population, and especially not only are the needs of these women so great, it sounds like there's real prevention that could happen and missed opportunities that is resulting in the death of young women. If everyone could type your questions into the QA box, I'll read them as they come in. But I have some questions just to start us off if nobody else has a question. And again, just type your questions in the Q&A box. Do you have an idea of the denominator? So among this population of young women, do you have any idea out of how many young women that, I'm sure you get asked this question a lot and it's very hard to answer, but do you have an idea of like what proportion of female sex workers do die? it like, let's say, I mean, it's hard to say, but like every year or over your study population, as you had, you're almost 3,000, that do you have an idea of how many?
Yeah, no, I think at this point, that's one of the major sort of missing questions for us. It would be great to have that variable in terms of what is the denominator, and it would certainly help with calculating mortality rates. But we don't have a very good sense of the population of female sex workers within any given country to be able to provide that information. And Brian may have less concrete, but sort of an estimate. I don't know,
Yes.
Brian, want to address that?
Yeah, so in some countries there are estimates of the population, but it doesn't necessarily get down to the city level where we work in the larger cities. But without a denominator, we can't estimate rates. So a lot of times maternal mortality, of course, is expressed in maternal mortality rate. So it's very difficult for us without a good denominator in order to make an estimate of the maternal mortality rate among female sex workers to compare with other women. But that is something we are working on with other people. It's one of the issues that came up that we understand is a real challenge from the 2019 study. And we are working with other people in order to try and determine alternative ways to estimate the female sex worker populations and communities so that we can make those estimates of a rate.
Okay. So Dina Fico has a question for you. She says, thank you for presenting this important research. Were any of these results particularly surprising for your team? Good question.
Brian?
I had conducted, along with my colleagues, the study in 2013 in Cambodia. And we were surprised there by the number of deaths. It was a much, much smaller study. Still, we were surprised that there were so many deaths in Cambodia among female sex workers from unsafe abortion when abortion is more accessible in Cambodia than other countries. So I would have to say that the very large number of deaths from unsafe abortion were a little bit of a surprise. I have to temper that, though, with saying one of the things that Wendy mentioned at the beginning, there are so few studies on causes of mortality among female sex workers that in a way, we didn't really know what we were going to expect. I would say the one thing that did surprise me was just the sheer number. It was so many deaths. So the proportion due to unsafe abortion, the number of women who died during pregnancy, giving birth, and after, and also Wendy can address it if she wants, the surprising number of deaths of pregnant sex workers during pregnancy.
Yeah, I think that that proportion of suicides was very surprising. Most of our literature points to the postpartum period as being the period in which we see suicides occurring, with the fetus in the womb being kind of protective during pregnancy from suicide. And that was not the case among these women. And we have enough detail from these deaths to understand that in some cases, the suicide deaths were pretty violent and pretty and involved the womb as well. One other thing that I just want to mention is that the proportion of deaths and the range of deaths related to abortion, suicide, murder was almost a surprise to our local partners as well, even to the organizations who work with female sex workers. And Brian can probably elaborate on some of those conversations. But even to them, it was surprising to see how many deaths were occurring among this population and from the causes that we were seeing.
Right. Well, one of the things that our partners are all well aware of is violence against sex workers, especially the violent and including violence that ends in murder. Oftentimes, the victims are found in a public location, so they and many other people are aware of those deaths. A woman may be murdered at night, and no one sees that, but they see her body the next morning. But the deaths that occur in the bars and brothels, in the homes where the women live after an unsafe abortion, or where the woman gives birth in the brothel and she, and including maybe the newborn, die in the brothel, then oftentimes, as Wendy mentioned, the brothel owner or someone else will take the body out and dispose of the body in a shallow grave, or even in a what our partners say is a dumpster, a trash bin. Because they don't want the police to know that someone died in the brothel and bring some type of police attention. So while there are many deaths among these female sex workers, many of them are really hidden. And that's why the best source of information about what happens to sex workers are other sex workers. They know what happens to their friends, their co-workers, and many times their relatives. They're working with their cousins or aunts or somebody else. So they're oftentimes the only people who know the details of what happens to the other sex workers who die.
So I have another question. As an HIV physician, I work in Haiti as an HIV physician, and we hear a lot about PrEP. And now there's going to be, long-acting cabotegravir PrEP. Do you feel like, but yet there's also, from your data, it would indicate that pregnancy is a very high-risk situation. So do you feel like there's adequate linkages being developed between groups who are able to offer perhaps long-acting contraception at the same time that we are providing PrEP? Because every HIV clinic, we have a large proportion of people who are sex workers. And do you see that as one potential opportunity, that if we're offering HIV PrEP, we should also be ensuring that contraception is available to the women? And if so, if it was available, do you think that the women would be open to accepting it? Or is there any stigma against contraception?
Again, going to the issue of how our 2019 studies and all of our other studies inform our future study. So the study we just completed in Kenya, Nigeria, and the DRC, we were asking those specific questions. So we'll be able to have a more definitive answer for you soon. But I think there's literature already out there about how reproductive health services should be integrated into HIV services. What is missing, though, in my review of the literature on linking reproductive health with HIV services, is it doesn't seem to mention at all the need for antenatal care incorporated in there also. So for the women who don't get reproductive health care and become pregnant, then where do they go? And many times I've talked with my colleagues who work in HIV clinics for sex workers, and they say, well, we don't do that here. We refer them to the local hospital or clinic. Then that just starts this cascade of barriers that oftentimes the clinics aren't, the women can't access the clinic during the hours that they're open because they work at night. So by the time they get to the clinic, it's closed. They really need to make money. And so if they're sitting in the clinic for 6 or 8 hours, they can't make money. They have to feed their kids. So there are a lot of barriers for the women to access antenatal care and safe delivery, including oftentimes discrimination and stigma. So these services, the reproductive health care, has been discussed, I believe, integrating into HIV services, but we also really need to integrate antenatal care. Now, one of the other things to do is maybe we need to have, you don't want to have silos, but it may be better in some communities to have antenatal care for pregnant sex workers separated from the HIV clinics. The other thing we're looking at, and I think is a important program to consider, is mobile outreach to pregnant sex workers who may not be able to leave the brothel for whatever reason, but if they can't come to the services, we need to go to them.
Just a quick follow-on question. Do you think I mean, I know we have a network of HIV clinics, but is a sex worker going to want to go to an HIV clinic? Because you certainly wouldn't want to be seen there, right? So it's, as there's a long-acting cabotegravir for long-acting PrEP for HIV negative women, do you think that's a new opportunity and should not be done in the HIV clinics, but rather maybe even at the brothels or somewhere else outside?
Again, looking at how our research informs our policies, we are talking with reproductive health organizations about opportunities to reach the sex workers where they are, including in the brothels. Yeah. So yes, we listen to them, and we listen to where it is convenient for them and why it is difficult for them to get services in other locations. You take a city like Lagos. You know, in some communities, they'll be able to go to the clinic, not a problem. In other parts of the city, they won't be able to. So it's not, you know, there's no monolith. We have to look at within each city, various communities, what works in that community and whether they can get there, and also whether it's safe for providers to go to that community to provide services.
So we have 3 minutes left and two great questions just popped up. So I'm going to read them both. So that you can address them at the same time. So Sridhar says, great presentation with important evidence among female sex workers. What next? Any short or long-term interventions happening to support the female sex workers? And I know you've, since this question popped up, you just did a great answer to that. And then Pooja says, how do you think about engaging with ministries of health and people in power to advocate for more resources for this population? I think, in fact, that is a great last question.
Very quickly, we respond as we hear from our partners and the women. During COVID, it was food insecurity. We responded by sending money for food. So food was a critical issue during the pandemic. And we literally raised money in order to feed sex workers and their children. So the other thing is, in our 2022 study in Nigeria, we found many sex workers who were dying during birth in the brothels in Nigeria. We have started the only program I know of in the world that specifically provides antenatal care and safe delivery to pregnant sex workers. So those are our responses. When we hear what's going on, we try and respond as quickly as possible. We don't have the money, so one of the things where we want to come out of this is we want to build other partnerships with other organizations. So I want everyone to know we're looking for people to work with and build on these strategic partnerships. So the last thing is we work with another group to operate an informal school for children of sex workers in Uganda. The other point, we have tried to reach out to the Ministry of Health in some countries. In some countries, it's easier than other countries. It is clearly going to be easier going to them now that the paper has been published than prior to the paper being published. I heard you say MOH. What were the other ones? I couldn't hear those.
Just people in power.
That's a major focus of our advocacy. I mean, it goes back to that issue that we made, that this can't be done without funding from governments, UN organizations, and foundations. We need funding from foundations and other sources in order to help these mothers and their children. That's a key message that has to come across here. The partnerships, we need collaborators and funding to help our local partners implement the programs that are needed in their community.
And if I could, I just add one point. It's also advocacy that needs to, that we support at the local level. So feeding back this information to the local partners so that they are aware as well of what is happening in their communities is really important for them to be able to advocate within country to those, government officials and people in power. And I think, kind of putting pressure from all sides is in terms of advocacy for these women who are often, not necessarily prime on anyone's list of people that need to be addressed because it's so hidden and because these problems are just not well studied in these countries.
Well, we've hit the end of our time, and we just want to thank you both for giving an incredible talk. It's a very disturbing talk. I think you've left all of us a feeling of we have to try to do more to help these women who are living in this horrible situation. And I just want to really thank you for drawing attention to this population of women that is so ignored and suffers so greatly. So thank you very much. I think you've also just given us a lot to work for, especially as many of us are HIV providers, and we don't always think about the horrible consequences that could occur from someone who does become pregnant when perhaps we could have done something to help in advance. So thank you very much for a wonderful talk. And I think I speak for everyone when I say we're not going to forget your words, and that you've really given us a feeling of a need to do something to help. And thank you.
Thank you.
Thank you.